Are you ready to learn with fun? Brace yourselves for the ultimate test of knowledge in the Cardiac Super League. Witness the clash of giants as 12 formidable teams step into the arena, battling it out for cardiology supremacy. In this exciting collaboration between Wilson's Pharmaceuticals and the Pakistan Cardiac Society, the Cardiac Super League promises intense competition and groundbreaking learning experiences. Stay tuned as the teams showcase their expertise, strategic brilliance, and unwavering determination. Who will emerge as the true champions in cardiology? The main goal of the case-based learning approach is to equip students and healthcare professionals to refine their clinical practice by learning the latest advancements. The Cardiac Super League awaits you, guaranteeing to advance your education. Join us and become part of an incredible journey. Visit our Facebook page or contact us for more information.
Assalamu alaikum everyone, this is 𝐂𝐚𝐫𝐢𝐚 and I warmly welcome you in Pakistan Cardiac Society's Cardiac Super League powered by Wilson's Pharmaceuticals. Today we are live for another exciting match between KTH Thrillers and FIC Fighters, and this will be the 6th match of Cardiac Super League. Allow me to introduce today's panel of experts. We have with us match referee of today's match, Professor Mohammad Ishaq. He is Professor of Cardiology at Karachi Institute of Cardiology, Heart Disease, and he is also chairing International Society of Hypertension Regional Advisory Group of South and Central Asia. And along besides him is sitting our guest panelist. He is a Professor Brigadier Abdullah, Professor Brigadier Zahoor Ahmed Khattak. He is Professor of Cardiology at FIC NIHD. And we are honored that President of Pakistan Cardiac Society, Professor Javed Akbar Sehal, have also joined us. He is Professor of Cardiology and Executive Director at NICVD Karachi. And from the Governing Council, we have Professor Fawad Farooq. He is Professor of Cardiology at NICVD Karachi. And two guest panelists have also joined us as a guest panelist of this match. Professor Brigadier Abdul Hamid Siddiqui. He is Professor of Cardiology at FIC NIHD Rawalpindi. And along with him is Dr. Imran Hamid. He is consultant cardiologist and he is also vice president of Pakistan Society of Echocardiography. And last but not the least, our moderator of today's program is Associate Professor Dr. Rajesh Kumar. He is Associate Professor of Cardiology at NICVD and he is also Pakistan Cardiac Society Chapter Coordinator of Karachi. So over to Professor Dr. Rajesh Kumar for moderating this program.
Thanks, Hamza, for inviting me and giving me opportunity for this nice activity which is going on nowadays. This is one of the it's kind of first activity which is happening in Pakistan, and this is wonderful activity for the cardiology fraternity. So after welcoming to all of my respected guests and teams, which today's the 6th match, which is in between the KTH Thrillers and FIC Fighters, and everybody knows about the rules and regulation that you people doesn't have to unmute your mic. The screen should be on. There shouldn't be any mentor or coach within the room. There's no reading material in front of you guys. And when there is a question from any side, the first question that will 0 mark, and the correct answer that will give you 6 marks. So now I am going to start for the toss between the KTH Thriller and FIC Fighters. So there is electronic toss.
Excuse me, sir.
And before the toss.
Sir, I just want to share that
Yes.
Chairperson of Cardiac Super League, Professor Feroz Mehman, has also joined us, and he's Professor of Cardiology and Vice Chancellor at University of Modern Sciences, Tando Mohammad Khan. Thank you.
Welcome, sir, Professor Feroz Mehman, sir. So before going to start this session, I request the teams, captain of the team, to introduce themselves. First, KTH Thriller. Please, Captain, introduce your team.
Assalamu alaikum. My name is Dr. Naveed, and to my right is Dr. Javed and Dr. Salahuddin, and to my left is Dr. Afasiyab Kundi.
And the FIC Fighters, please, captain of the team, please introduce your team.
Assalamu alaikum. My name is Dr. Imad. I have Dr. Aisha Iqbal and Dr. Bazga Faisal and Dr. Aisha Ramzan with me. So this is FIC team.
So we are ready now. Both the teams are ready, and now we are going for the toss. Electronic toss there and flip the coin. KTH Thriller, they will ask about.
I'll choose heads.
It's head.
KTH Thriller chooses the head, and it's head. So KTH Thriller, you want to take the question first or want to throw the question first?
I want to throw the questions first.
So FIC Fighters, now it's your turn for the batting.
Okay, sir, we're ready.
So KTH will be throwing the question.
Yeah.
KTH scenario will be presented first.
Sir, yes. A 34 years old normotensive normoglycemic male volleyball player presented with syncope. On examination, BP was 120/80, pulse 60 per minute regular, S1/S2 audible and no added sounds.
We are not having the screen visible. Please make sure that we can see the screen of MCQ, please.
Yeah, screen is not visible.
सर कार्डिक सुपर लीग की स्क्रीन को पिन कर दे सर काइंडली। माजिद अगर आप मेरी बात सुन रहे हैं तो कार्डिक सुपर लीग की स्क्रीन को पिन कर दें प्लीज।
ये उसी को पिन किया हुआ है
यार, उसको पिन करने से आ जाता है, मेरे पास तो आ रहा है। डबल क्लिक
सर अब विजिबल है आपको?
मुझे तो आ रहा है, आई डोंट नो।
मुझे विजिबल नहीं है सर।
कि वो पिन करेंगे, आप कार्डिक सुपर लीग को पिन करेंगे, जो पार्टिसिपेंट इसमें है उन सबको विजिबल हो जाएगी स्क्रीन।
हाँ,
थैंक यू।
अब विजिबल है, अब पढ़ें।
जी सर विजिबल है। प्लीज KTH टीम प्लीज रीड योर सिनेरियो।
A 34 years old normotensive normoglycemic male volleyball player presented with syncope. On examination, BP was 120/80, pulse 60 per minute regular, S1/S2 audible, no added sounds. Chest is bilateral clear, abdomen is soft and non-tender with no 𝐻𝐵 and TECT CNS. His oxygen saturation was 98% at room air. ECG was done with short sinus rhythm and rate of 60 per minute regular. T-wave inversions in V1 to V3 and occasional PVC. He had history of blunt chest trauma while playing. Family history is positive for sudden cardiac death.
Please go ahead with the questions. Let's not waste time.
Go ahead with your
Sir, first question, please.
with your options, please.
Question number 1, 𝐂𝐚𝐫 in an athlete occurs due to option A, blunt trauma to chest during myocardial depolarization may lead to VF. Option B, blunt trauma to chest during myocardial repolarization and depolarization may lead to VT and VF. Option C, blunt trauma to chest during myocardial depolarization may lead to VF and VT. Option D, blunt trauma to chest during myocardial repolarization may lead to VF. Option E, blunt trauma to chest during myocardial repolarization and depolarization may lead to VT.
Timer start now. Forty seconds remaining.
Answer D, delta.
Answer is correct. Option D.
Well done. Question number 2.
Network issue is over here.
I think KTH can ask the second question.
Question number 2. Mutations in genes accounts for ARVD in 40 to 50% of patients. Mutation in which of the following gene is responsible for ARVD? Option A, phlcopelin-3 gene. Option B, desmoplakin gene. Option C, SCN5A gene. Option D, desmocolin-3 gene. Option E, desmoglin-3 gene.
A. Choose answer A.
I think you have time, FIC. You can wait, discuss it. Because it's all 90 seconds is yours.
Okay, sir.
So-
Okay.
Yes, if you're sure, you can come up with
Option
your
A. Option A.
Okay. So I think Hamza locked the option A. Let's see what KTH says about it. Is it right or wrong?
Wrong answer. Correct answer is option B.
Okay. So the second
Okay,
ball.
so move on. Second ball missed. So now
Yeah.
move on third question.
Yeah.
Question
Yes,
number
Kate.
3. In athletes, which of the following is not abnormal pattern in ECG? Option A, junctional escape rhythm. Option B, LVH with STT abnormalities. Option C, deep inferior or lateral T-wave inversions greater or equal to 2 mm. Option D, frequent PVCs greater than or equal to 2 per 10-second tracing. Option E, intraventricular conduction delay greater or equal to 140 milliseconds.
Okay. Let's start the timer.
Your time is start now.
A.
Okay.
No.
Yes, KTH, what do you think about the answer? Is it
Sorry,
right or
sir.
wrong?
What is their answer? Sorry,
The
sir.
A, alpha.
A.
A.
A is
Junctional escape.
correct answer. Correct answer.
Okay.
No, no.
FIC is betting well. 12 of 3 deliveries. Very good. So let's come up to the next question.
Question number 4. Regarding ARVD, which of the following is correct? Option A, RV apex and interior wall are not commonly involved. Option B, lead potentials on signal average ECG are sensitive for ARVD diagnosis. Option C, ARVD process starts at endocardial level. Option D, VT ablation is only effective if ablation is performed at endocardial level. Option E, all are correct.
Okay, let's start the timer. And FIC, be ready. I think Rajesh have some issues with his net connection, but the moment you are in, you can take on from me. All the questions are really revolving around syncope, arrhythmias, and so more of an electrophysiology quiz. Difficult, but it's part of cardiology. Yes, FIC. Last 30 seconds.
Last 30 seconds remaining. Fighters are fighting very well. Last 10 seconds.
E option. E option.
E. Okay.
The answer is wrong. Correct option is option B.
Oh,
Okay.
you miss another delivery.
Okay. Next question.
Okay, move on. Next question.
Question number 5. Which one of the following is a part of minor criteria according to modified task force criteria for ARVD? Option A, non-sustained VT of LBB morphology with inferior axis. Option B, non-sustained VT of LBB morphology with superior axis. Option C, sustained VT of LBB morphology with superior axis. Option D, regional RV dyskinesia. Option E, regional RV aneurysm.
The timer is started right now. By 2 missed deliveries, the competition is going tougher right now. So fighters, please play. Last
A. Option A, alpha.
Correct answer. Option A. Oh.
Do we have Rajesh? So I think let's move on to the next question.
Question number 6.
Yeah.
Echo, family history, and MRI of the above patient confirm the diagnosis of ARVD. Which of the following is not the ECG feature of ARVD? Option A, QRS greater than or equal to 110 millisecond in V1 to V3. Option B, abnormal QRS in leads V6. Option C, delayed S upstroke, neither of S to end of S in QRS of V1 to V3 greater or equal to 55 millisecond. Option D, RBB. Option E, a small deflection epsilon wave immediately after QRS.
Sir, I would request FIC fighters to please keep the mic in unmute mode during formulating question answer.
Yeah, I think it's good. It make more live to the session because we'll be hearing what you're discussing in between.
One broad होते हैं, QRS broad होता है. B के बारे में श्योर नहीं है. Delete S stroke ये भी होता है. E कंफर्म है. अब B और D में कंफ्यूजन है, ठीक है? C है.
C, B, D, B और E है.
ठीक
ए
है
और बी बताओ।
ए है
ए है, बी
ए
है,
है
फिर
abnormal QRS
डब्ल्यू की है लेटर होता है,
RBB उसका फीचर है या नहीं आई एम नॉट श्योर
भी है, आरबी
नहीं उसमें इंक्लूडेड है या नहीं RBB होता है पार्शियल RBB होता है RBB को छोड़ देते फिर abnormal QRS लीड B6 आई थिंक उसका यही ख्याल है बाकी तो सारे हैं QRS होता है ब्रॉड होता है B और D है RBB होता है RBB होता है ऑप्शन B abnormal QRS and lead B6
Correct
Okay,
answer. Option B.
correct answer. Very good. FIC, you're playing really very well. 24. Yes, next question.
Question number 7. 6 months later, the above patient was diagnosed for complicated ICD infection with vegetations on ICD leads. Which one of the following is correct? Option A, full device explantation and treatment for 8 to 10 weeks with IV antibiotics. Option B, full device explantation and treatment for 4 to 6 weeks with IV antibiotics. Option C, IV antibiotics, treatment for 3 to 6 months. Option D, full device explantation and treatment for 3 months to 4 months with IV antibiotics. Option E, full device explantation and treatment for 3 to 6 months with IV antibiotics.
Your timer is started right now.
अगर उस पे वेजिटेशन है तो हमने
लेकिन मुझे अब देख लो 3 to 6 months कितना लंबा होता है?
मतलब we're dealing with the case of endocarditis on the leads
Okay.
हाँ क्योंकि ये एक सोर्स हमने रिमूव कर दिया है उसका
जब सोर्स रिमूव कर दे तो हम नॉर्मल ड्यूरेशन ऑफ
और वैसे भी
देंगे ना, बी नहीं लग रहा?
हाँ मेरा भी यही ख्याल है 4 to 6 weeks would be fine ये वाला 4 to 6 weeks
ये उसमें से आया है लेकिन मुझे याद नहीं आ रहा एग्जैक्ट ड्यूरेशन मैंने ख्याल है 46 वीक्स है।
ओके अब 4 to ठीक है 4 to 6 weeks है या फिर 3 to 6 months है
30 सेकंड रह जाएंगे ना तो हमने हर एक का आंसर करना है। 3 to 6 में बहुत ज्यादा नहीं लगता।
3 months 8 weeks में क्या फर्क है अगर
ठीक है 46 ए या बी ना हो
4 to 6 B option I think
go for B.
answer B beta
Yes, KTH.
What about B? Answer B. Should we lock?
Right.
Great.
KTH, please unmute your mic. KTH Thrillers, please unmute your mic.
Fighters are playing very well.
Question number 7 answer is correct.
Okay.
So the score is now 30. So please move on another question.
Question number 8. Regarding ARVD treatment, which of the following is incorrect? Option A, ICD is indicated when there is RV dysfunction and syncope. Option B, ICD is indicated when there is LV dysfunction and syncope. Option C, ICD is indicated when there is a heart failure. Option D, ICD is not indicated when there is NSVT. Option E, ICD is indicated when there is VT.
देखिए VT के साथ तो करनी है ना हमने इनकरेक्ट है ना
डी लग रहा है इनकरेक्ट एंड देयर इज अ हार्ट फेलियर में क्यों करना है हार्ट फेलियर में क्यों करना है देखो सी है
आरवी और एलवी डिस्फंक्शन में हम आईसीडी डालते हैं वो इट कुड बी एआरवीडी जो है ठीक है हार्ट फेलियर ठीक है सी है नॉन सस्टेन वीटी में भी नहीं करते वीटी में करते हैं तो मेरे ख्याल से हार्ट फेलियर जो है उसमें आईसीडी का कोई रोल इतना बनता नहीं है आईसीडी में होगा तो सीआरटी दे देंगे वो उसको वो भी कर देगा बी भी कर देगा
डी भी बनता था लेकिन उसने नॉट लिख दिया तब तक
हाँ
वो सही हो गया
हाँ
इंडिकेटिव व्हेन देयर इज अ हार्ट फेलियर तो सी है
बिल्कुल सही
गो विद द सी
ऑप्शन सी
Wrong answer. Correct option is option D.
Oh, you missed another delivery. So Please play carefully for the next two questions. Go ahead with next question. Question number 9.
Question number 9. 3 months later, the above patient presented with VT. Which of the following helps to differentiate between ARV-DVT and RVOT-VT? Option A, verapamil. Option B, flecainide. Option C, adenosine. Option D, amiodarone. Option E, sotalol.
And your timer is started right now.
No technique ganas. No technique ganas. Veamos sir. Garaki.
आयशा
नहीं हाँ
ये भी एमसीक्यू है कहीं मैंने पढ़ा हुआ है मुझे भी लग रहा है
फ्लेकेनाइड फ्लेकेनाइड का
ये अगर आपने डायग्नोस करना है
verapamil आई थिंक सो वो उसको अबॉलिश करेगी ना
क्योंकि वो पर्टिकुलर वीटी है ना
हाँ
verapamil
तो मेरा भी यही ख्याल है
लेकिन उन्होंने कहा है लेकिन आप ध्यान से खेल लें
So it looks like as a arthmogenic competition.
मेरी बात सही है एक वो हाँ तो अगर हम देंगे वो डिफरेंशिएट कर देगा कि ये VT ARVD वाला है या ठीक है ऑप्शन ए verapamil
Wrong answer. Correct answer is option C, adenosine.
Oh, you missed another delivery. So the last question is remaining. So please go ahead with last question.
Question number 10. Which of the following is the echo feature for ARVD? Option A, regional RV 𝐂𝐚𝐫 and RVOT on long axis greater or equal to 36 mm during diastole. Option B, regional RV 𝐂𝐚𝐫 and RVOT on short axis greater or equal 30 mm during diastole. Option C, regional RV 𝐂𝐚𝐫 and RVOT on long axis greater or equal 32 mm during diastole. Option D, regional RV 𝐂𝐚𝐫 and RVOT on long axis greater or equal 28 mm during diastole. Option E, regional RV 𝐂𝐚𝐫 and RVOT on short axis greater or equal 28 mm during diastole.
This look and has an easy question.
डायस्टली में है अब इसकी जो लॉन्ग
right now.
एक्सिस में रीडिंग है वो 30 प्लस है और इसमें जो है वो शॉर्ट में इसमें लॉन्ग में ना 32 के करीब थी नहीं ई नहीं है मुझे ए लग रहा है या बी लग रहा है हाँ या ए लग रहा है या सी लग रहा है ए लग रहा है या सी लग रहा है लॉन्ग एक्सिस हाँ ठीक है चलें 36 ज्यादा है 36 कर ले गट फीलिंग सी की तरफ आ रही है लॉन्ग एक्सिस वाला ऑप्शन सी
Correct answer, option C.
ओके ऑप्शन नंबर बी को ऑप्शन नंबर 2 को काइंडली क्वेश्चन नंबर 2 को रीचेक कर लें प्लेस्मोप्लेकिन मोस्ट कॉमन जीन होती है एक दफा उसको रीचेक कर लें क्वेश्चन 2 को प्लीज इफ पॉसिबल
मेरा ख्याल है ये जो कंट्रोवर्शियल क्वेश्चन होते हैं ना इसको बाद में रिव्यू करना चाहिए अभी तो एज इट इज आई थिंक यू टेक इट then the team which has formulated those questions they should give their explanation तो आपका जो ऑब्जेक्शन है उसके ऊपर वो इनको KTH वालों को रिकॉर्ड करना चाहिए and they should give an explanation
agree sir. But the question board is here which showing they played really well and 36 is a score for fighters. So we are now moving to the thrillers. Thrillers, you are ready to take the questions?
Yes sir, move ahead.
Okay, move ahead fighters please.
Yes, FIC Fighters, you can start your questions.
Year-old male athlete with a medical history of hyperlipidemia, hypertension, and chronic reflex esophagitis, presented to the hospital with chest pain in the middle of the chest. The pain was accompanied by shortness of breath and worsened by coughing for the past 2 to 3 days while engaging in physical activity. Upon examination, no significant abnormalities were found. A 12-lead ECG revealed inverted T waves. The total leukocyte count was measured at 12,000. Drop eye level was 0.22 nanogram per ml and CRP was greater than 200. A cardiac ultrasound revealed the presence of pericardial effusion surrounding the entire heart.
Okay. Sushil.
Once again, read the question because question is lengthy. Read the question and then go to the options.
A 40-year-old male athlete. Okay. Question. For the a 40-year-old male athlete with a medical history of hyperlipidemia.
I think it has been done. Now we should go to questions.
Yes, I think if KTH is satisfied with the explanation of the question, we can go to the options.
KTH, are you satisfied?
Sir, please show the scenario.
Okay, they want the display of the
Okay,
scenario.
go ahead.
So whenever you are ready for the options, just say, okay, we'll start with the options.
Okay, sir, move to the questions.
Okay, FIC.
Okay, move to the options.
For the above mentioned patient, which of the following would be the most appropriate next step? Option A, serial ECGs. Option B, chest X-ray PA view. Option C, repeat troponin level. Option D, initiate pre-medication with aspirin and clopidogrel. Or option E, conservative management.
Serial ECGs, chest X-ray, repeat eye level, initial pre-medication, load.
I think KTH, what you can do, you can discuss your options loudly in Urdu so that we can also enjoy your conversation.
Okay, sir. Serial ECGs का क्या होगा? Serial ECGs तो inverted T waves है, troponin normal है.
X-ray में
Just X-ray.
Repeat operations level. Methods moderately elevate
pericardial effusion में
जरूरत है load conservative नहीं pericardial effusion वो MI के साथ नहीं होगा हाँ अगर pericarditis तो क्या है repeat operating नहीं है क्या मतलब conservative ये सब मगा
next step
चलो
option E.
Yes, option E
Please
is
lock
correct.
to option E.
शाबाश good.
Great opening.
Great, go ahead.
Yes,
Take care
FIC
of the
next.
first delivery. Please go ahead with second question.
Which of the following statement accurately describes the anatomy and physiology of the pericardium? Option A, the pericardium allows for extensive distension of cardiac chamber, facilitating increased filling during exercise and periods of increased cardiac output. Option B, congenital absence of pericardium is an extremely rare condition that is incompatible with life. Option C, the pericardium is composed of multiple layers, including the visceral pericardium, fibrous pericardium, and parietal pericardium. Option D, innervation of the pericardium is predominantly supplied by the vagus nerve, facilitating autonomic control of cardiac function. Option E, all of the following statements are correct. accurately depicting the intricate anatomy and physiological functions of the pericardium?
Anatomy, physiology, pericardium.
ये गलत है बी गलत है बी गलत है compatible बी compatible
Option A.
बी ई हुआ सा
CDA. CDA. Extension of the cardiac chambers, facilitate increased filling during exercise. C. The innervation of the brain is predominantly supplied by the vagus nerve, facilitating autonomic control of cardiac functions. A. Distension of cardiac chambers during exercise.
सी डे रखा जाए ना सी भले की है पूरा ई आउट शी करना मन अदर ई आउट शी ड्रिल हां देखिए पूरा ई आउट शी करना ई ना बिया दा बोल आउट शी सिपाती की आइदर ये वो है करना आइदर ई या आइदर सी बट सिंपल दे सी ठीक है सी दूंगा ना सी दे नॉट भी लगा ना सी को नॉट भी ना एक माइनर भी ना फिजियोलॉजी दा अब सी नॉट भी ना
Answer C.
Is correct.
Yes.
Yes, FIC, move to the next question.
On further examination, the patient temperature.
Upon further examination, the patient's temperature is 37 degrees centigrade and his echo reveals moderate pericardial effusion without signs of tamponade. The male attendant requests admission to the emergency ward. Which of the following is a predictor of poor prognosis in this patient and a criteria for admission? Option A, acute onset of symptoms. Option B, fever of 37 degrees centigrade. Option E, lack of response to brufen and colchicine.
मॉडरेट ब्रिकार्डिक एफ्यूजन को हम एडमिट करते हैं मॉडरेट
ना एक्यूट ऑनसेट
सीवियर एडमिट
हमारा एक्यूट ऑनसेट ऑफ सिम्टम्स जो हम देखा ना एक्यूट पेरिकार्डियल एफ्यूजन जो हम सिम्टमेटिक एडमिशन क्राइटेरिया है chronic moderate या large amino doesn't matter करना
सही ना तब किसी को हमें बी में और बी तीन में माखदा से पड़ा कोई करना चाहिए एक्यूट मॉडरेट ही करना या सीधे या ई
ना the acute onset of symptoms वाले ना acute pericardial effusion मेरे ना
poor prognosis of admission सिर्फ admission ना poor prognosis poor prognosis also और नो ई ठीक है ना poor prognosis ई के
मतलब ए वन है ना acute onset of symptoms
acute fever
poor prognosis है
athletes
oh yeah observe
Saudi ना possible E or C home possible most likely can moderate pericardic effusion because I study moderate pericardic effusion you will admit the patient but prognosis emergency
option C.
Okay, Hamza, lock and let's FIC, is it right or wrong?
It's wrong. Option E, lack of response to brufen and colchicine is right.
Then we take
Okay, move on to the next question.
Next. Poor prognosis.
The patient was prescribed with ibuprofen 600 milligram TID for 4 to 6 weeks and colchicine 0.5 milligram BD for 6 weeks, and his fresh labs were sent and was called for follow-up in next 2 weeks. On next visit, he states that his pain has gone better, but he still feels febrile sometimes. ECG shows mild ST segment elevation. His CRP is 110, TLC count is 10,500, trop I is 0.09. which type of pericardial syndrome he is suffering from? A. Acute pericarditis, B. Incessant pericarditis, C. Recurrent pericarditis, D. Chronic pericarditis, or E. Myopericarditis.
Myopericarditis में देखिए drop इसकी.
KTH, we are learning a bit of Pashto from your discussion, but it will be good if you discuss in Urdu so that everyone would really appreciate the discussion.
Acute pericarditis तो पहले था between incessant pericarditis, chronic pericarditis. Myopericarditis तो नहीं है ना उसमें पानी ज्यादा होता है. Drop भी acute pericarditis तो वो तो already अभी 2 weeks के बाद है. कितना टाइम pericarditis कितना recurrent recurrent भी नहीं है. 2 weeks तो chronic में टाइम नहीं 2 weeks है 2 weeks. 6 weeks then 2 weeks बाद है and उसका follow up and next 2 weeks है ना follow up next 2 weeks. हाँ ये session क्या है? recurrence नहीं है. CRP condition है ना recurrent probably नहीं थे one on CRP कम हो गया ना तो उसमें क्या है.
So last 10 seconds.
recurrent में किसी ने क्लिक की और तो वीडियो मुझसे.
Option C.
Yes,
Option C is wrong. Option B is correct. Incessant pericarditis.
Okay. Okay, next question. Yes, FIC, next question.
What is the recommended time frame for resuming exercise after an episode of acute pericarditis? Option A, exercise should be resumed immediately after the resolution of symptoms. Option B, a 2-week rest period is recommended before gradually returning to exercise. Option C, exercise should be deferred for at least 3 months to allow complete healing of the pericardium. Option D, resumption of exercise should be guided by individual symptoms and clearance from a cardiologist.
Exercise should be within immediate symptoms. No, okay, I should not be there. Because pericardic fusion. 2 weeks period of recommendation before gradual returning to exercise. 2 weeks plus recommended. B के बारे में क्या है? B 2 weeks rest period is recommended. Yeah, exercise should be deferred for at least 3 months to allow complete healing of the pericardium. 3 months is a huge time. Rest 6 weeks मानने में आओ तरीका ना 6 weeks मानने में किसी इधर सी yes 6 weeks. I'll take 6 weeks और I'll take 2 weeks और 6 months 6 weeks treatment है करूँ but treatment के chain में वो 2 weeks नहीं 3 सी देगा specific recommendation क्या है recommendation ये 2 months 6 weeks के लिए तो उसको वो मिल जाएगा treatment तो 2 weeks के बाद कैसे वो resume करेगा सी है ना.
Option C.
Yes, option D is correct. Resumption of exercise guided by.
Yes. FIC, next question.
The question is equally out of 4.
Vaccine has been shown to prevent recurrence of pericarditis after an initial episode in which of the following trial? CORP trial, COPE trial, CORNET trial, or CORPL trial?
Last few balls are very difficult. Let's see. These are pure recoil questions.
KTH Thrillers, please play carefully because it's 6th question and your score is 12.
Oh.
40 seconds remaining. Last.
Option B, 𝐶𝐞 trial.
Fighters, please lock the option B.
B is correct.
Great going. Move on, next question.
Okay, 3 minutes, cool.
Which of the following features would indicate cardiac tamponade rather than constrictive pericarditis? Raised JVP, B, muffled heart sounds, C, no Y descent on JVP, option D, hypotension, or option E, tachycardia?
C, no, I say C.
So the timer is started right now.
C, yes. Why decent getting? Why decent destiny? Destiny. No, why decent? Yes.
There's JVP.
We have time, okay? We can discuss. We have time. So. Hypertension are there in constrictive pericarditis. Yeah, whereas JVP is the current both.
Option C.
Correct.
Still 40 seconds are remaining. Okay, great. Great going. Fighters have to fight well because Thrillers are on the fielding mode right now. So move on to question. Next question.
Is not a recommended therapeutic option for recurrent pericarditis. Triple therapy of aspirin called C, high dose prednisolone, or D, aspirin or NSAID with colchicine.
Which is not recommended. Pericarditis is recommended. High dose prednisolone is recommended.
Option is recommended.
Aspirin, NSAID, and colchicine. Look, steroids in recurrence is recommended. Aspirin, NSAID, colchicine.
Aspirin, NSAID, and colchicine.
For recurrent pericarditis.
Recurrent
high dose of prednisolone, okay, yes. But recurrence is very high. Look, recurrence is very high in prednisolone. High
बार हो रहा है रिकरेंट में स्टेरॉइड नहीं देते रिकरेंट में स्टेरॉइड नहीं देते हैं एस्पिरिन और कोल्चिसिन है ना वो भी
aspirin and NSAID we are giving in acute. We are giving in acute. High dose prednisolone.
से हम
high dose prednisolone.
और रिकरेंट सब क्या
ऑन कर मार्क दो
Option C.
Option C is correct.
Yes, very good.
Great going. The two questions are remaining right now. Move on next question.
Need 2 sixes and 2 balls.
Following trials demonstrated the benefit of colchicine in the treatment of acute pericarditis. Option A, CORP trial. Option B, ICAP trial. Option C, COPS trial. Option D, APEC trial.
The epic measurement है
Huh? Come here. कौन सा? Epic? No, which one? Which one? See? कोचिसिन मान लेगा ना, कोचिसिन नाम से भी देख सकते हैं ना, अगर वो नहीं है, अगर कंफर्म नहीं है तो नाम से भी देख सकते हैं। ये देखिए कोचिसिन रिकॉर्ड भी कर रहा है टू स्ट्राइक, अब फिर कॉर्प है, कॉर्प
The last option was core prime क्या था उसमें जो epic में epic हाँ yes
अच्छा
epic
ऑप्शन डी डेल्टा
D is wrong. Option B is correct.
I can pericarditis देगा ना acute I can
Okay. Yes, next question.
अब मुकाबला सख्त है अब। हाँ
Yeah.
ये सुपर ओवर पे जाएगी बात।
Which of the following echocardiography finding is more consistent with constrictive rather than restrictive pericarditis? Option A, elevated E by E prime ratio. Option B, thickened pericardium. Option C, normal respiratory variation of mitral inflow velocities. Or option D, increased lateral annular E prime velocity.
consistent with constrictive pericarditis.
is lateral annulus velocity normal respiratory variation of lateral velocity कम है constrictive की कम है बोले चाह कर medial जाते हैं देखो ये रेशो को बाउंस है restrictive customers या भी दे ऐसे
Restrictive के बत्ती करें, restrictive के बत्ती करें, restrictive में तो करें।
That's the last option.
हाँ, तो सब है। सी
ना restrictive के लिए non-respiratory variation
मार तो उधर
see
और होगी चलो 10 मिनट ऑप्शन सी
Yes, FIC.
Option C is wrong. Option D is correct.
Oh, great. So
सुपर ओवर पर बात नहीं गई, सुपर ओवर तक बात नहीं गई।
Yes, it's the last ball which has decided. So, congratulations to FIC Fighters for winning. I think they're the first match of their opponent. Well played, KTH too. They almost come closer and almost about to equalize, but unfortunately, on the last ball, they're unable to make it. So it's a very fine and good match between the two. So I think let's move on to the comments. Whoever is available, I think Javed is there.
First of all, yes, Professor Javed sir.
Thank you very much. Today, the first time I have been part of this whole match, and definitely, if you honestly ask me, I have improved my knowledge, and sometimes I felt very difficult to choose answer, and I appreciate people who made these questions. And definitely, it's not only being a part and being supervising the things, but definitely it's a learning experience. And I'm very impressed that Professor Ishaq has also completed whole the meeting, and definitely he has also enjoyed learning this meeting. And definitely if the people like Professor Ishaq and Professor Feroz, they become part of this engagement or educational activity, definitely it boosts a lot of juniors and intermediate people like Rajesh Kumar And I myself can count in intermediate as well, because being their patronship and being their involvement in these kind of activities means a lot for us and for juniors. And definitely at the end of the day, somebody is winner and somebody is loser. But because 12 teams, 1 year whole practice, it will add a lot of educational and information and education to all of us. And I congratulate Wilson Pharma also for making this initiative, and they will come more innovative ideas in future as well. Thank you very much. I think जो टीम से वो अपनी माइक जरा म्यूट कर दें ताकि जो बाकी बातें हों तो कंक्लूजन की तरफ जाएं.
Okay, I think I would like to make my comments now, because we have to go somewhere to meet Professor Suhail. First of all, I would like to congratulate both the teams for a very good fight that we had seen this morning and afternoon in Pakistan. And I agree with my dear friend Javed Akbar Syal that it is a great learning experience for us as well, because the standard of questions and answers are really very good and very thought-provoking as well. So beside me sitting is Brigadier Zahoor, and we have been discussing the answers, and some of the answers we found quite difficult to choose from the options given. So that tells about the standard of our fellows that are now coming up in the market. So it's a great effort both the teams have made, and as pointed earlier, somebody has to lose, somebody has to win, but that's a game, and they should take it with a sportsman spirit. But I think that this kind of activity is really going to provoke a lot of reading, a lot of literature search. I get these reviews and I have to go through a lot of references to make my comments, because it's so difficult to choose from the options, because options are so close to each other. So I think Wilson Pharmaceutical needs to be complimented for this whole effort. I've been part of the all the sessions so far. This was the 6th time, and each Saturday morning my weekend here is taken by Wilson, you see, because here in the morning we find it very difficult to get up so early, and but anyhow, it has been a great pleasure to be part of this whole exercise, and we look forward to the final one day when we'll have the final awarded the medal. But I hope that that cup should not become a cricket cup in Pakistan, and it should be a pure academic cup and not a sports cup. So I think with this, I would like to ask my dear friend Professor Zahoor is also visiting UK, and he was staying with me, and I told him in the morning we have this exercise. He wanted to go for shopping, and I told him first we have to face this webinar and then we'll go for shopping. So I'd like Zahoor to say a few comments about it.
Thank you very much for inviting to this great academic activity. It was a wonderful experience, also thought-provoking to all of the questions. I will definitely continue with this education activity, inshallah. Thank you, sir.
So if there are no other comments,
Any
I would
comments
like
from
to...
Professor Fawad Farooq?
Yeah, I think if you have Feroz Mehman or
he has
Dr.
gone in some
Abdullah.
lecture.
Okay. I think all had been said. I think let's Professor Ishaq conclude the session. We'll be ready for the next match on next Saturday.
Sir, we want to take comments from guest panelists, Professor Abdul Hamid Siddiqui and Dr. Imran Hamid.
Yeah.
So, Dr. Abdul Hamid Siddiqui, sir, please comments from your side.
We don't see him on the video.
Sir, he's present.
I think it's a great academic activity, and as Professor Ishaq has already summarized, I think we keep on learning even as facilitators, and the questions are, I mean, the MCQs are so they look so close to each other that every bit is correct. Obviously, out of all these, one has to be correct, and we have to go to look for these reference books to be good at it. I think it's a very good academic activity.
So thank you very much, Dr.
I forgot to congratulate and compliment the moderator of the day, Dr. Rajesh Khanna. Dr. Rajesh, I would say Rajesh Khanna, nahi hai, Rajesh.
Rajesh Khanna.
Rajesh Kumar.
Rajesh Kumar.
And for his moderation, and I would take your leave. Thank you very much, everybody. And I think
the final comments from
will...
Dr. Imran Hamid.
हाँ आप हाँ वो फारूक साहब ले लेंगे मुझे इजाजत हो तो मैं इनको डॉक्टर साहब को ले जाऊंगा
Thank you very much for your time.
Okay, sir. Enjoy your shopping.
Thank you.
Dr. Imran Hamid, if you can listen, please comments from your side.
Assalamu alaikum. It was a very nice exposure and very nice experience. Both the teams were very well prepared, and I would like to congratulate the FIC team because they are upfront with some very, very difficult question. Because ARVD is a really rare disease, but they answered questions very well. And I will like to make a comment that whenever you do an echo, always measure the RVOT, because only then you can pick up such cases. One thing. And second thing is that these guys, they should come prepared with the guidelines. They must read the guidelines thoroughly, because guidelines tell you each and everything from the beginning till the end about the trials as well, because the students, they lack in the trials knowledge. So I recommend them to read the guidelines fully. But still, it was a very good experience. I congratulate both the teams. They really had good knowledge of the subject. Thank you.
So thank you very much. And final concluding remarks from Professor Fawad Farooq, please.
I think overall it was a very nice activity, and with every day we are improving on questions, audience participation, involvement. So I think overall very nice activity. Congratulations to FIC and well played KTH as well. So it's all over from our side. Let's meet next time, next match. Hamza, it's over to you.
So thank you very much. Once again, on behalf of Wilson's Pharmaceuticals, I would like to congratulate FIC Fighters for putting up such a splendid efforts, and commiseration for KTH Thrillers. They are not out of the tournament still. They have a match to play, I guess. And I'm also thankful to all the panelists, Dr. Fawad Farooq, Dr. Javed Akbar Sayar, Dr. Ishaq, Dr. Zahoor Khattak, Dr. Abdul Hamid Siddiqui, and Dr. Imran Hamid, and Dr. Feroz Mehman for participating and taking time out of their busy schedule for this match. And with this, I would like to sign out, and Allah Hafiz and take care.
Are you ready to learn with fun? Brace yourselves for the ultimate test of knowledge in the Cardiac Super League. Witness the clash of giants as 12 formidable teams step into the arena, battling it out for cardiology supremacy. In this exciting collaboration between Wilson's Pharmaceuticals and the Pakistan Cardiac Society, the Cardiac Super League promises intense competition and groundbreaking learning experiences. Stay tuned as the teams showcase their expertise, strategic brilliance, and unwavering determination. Who will emerge as the true champions in cardiology? The main goal of the case-based learning approach is to equip students and healthcare professionals to refine their clinical practice by learning the latest advancements. The Cardiac Super League awaits you, guaranteeing to advance your education. Join us and become part of an incredible journey. Visit our Facebook page or contact us for more information.